This
jump in
conference will now be recorded.
as we move through. So, as we all know, CMS, Medicare have made ongoing efforts in the last 6 to 7 years to move towards different value-based models. And there is a brand new one that's coming to market next year for red, white, and blue Medicare. And it's called a direct contracting entity. Similarly, similar to an ACO, it builds upon that Medicare shared savings model and partners with primarily Medicare Advantage payers in the market to leverage what they have learned about managing a population and using that to administer more efficient healthcare with higher quality objectives, to a red, white, and blue population. And so to that end, we have partnered with Clover, an established Medicare Advantage payer in the market. They started in New Jersey and came into Georgia about 3 years ago and are gearing up for close to a statewide expansion for next year. And they are also going to be launching for traditional Medicare, their direct contracting entity in April of 2021. And so just, to recap what really the program goals are, I think we're all well familiar with CMS's triple aim: better patient outcomes, higher quality care, more efficiently, really helping Medicare beneficiaries engage in their healthcare decisions and have better outcomes on the back end. So really, who is DCE looking to partner with? There are really two types of partners that they are engaging with. One is a participant provider. In most cases, this would be a primary care physician who is going to have attributed lives. So they attribute very similar to an ACO is, with the preponderance of primary care being how patients are aligned. They also do partner with what they consider preferred partners. This would be groups of specialists or subspecialists that may not have attribution, but are interested in more overall population health management and learning more about value-based care. So those are really the two provider groups that they are looking for. So eligible providers and suppliers, a little bit different than an ACO. They're focused much more on physician and other provider type partnerships. So physicians, physician networks, FQHCs, RHCs, and critical access hospitals. So how does a DCE work? They operate very similarly to an ACO. In this case, Clover, as the DCE partner, is taking the full responsibility for overall cost and care rendered to the population that is attributed through their primary care partners. And so for Medicare beneficiaries, however, nothing changes. They still have the flexibility to see any Medicare provider, still self-directed for specialist care, what they're looking for. So nothing really changes from the beneficiary perspective, but Clover does have a responsibility for managing the overall spectrum of care. So what does it mean for the provider themselves? So this is really relevant to a participating provider, not a preferred partner, someone who has attribution that is coming through the model. So you will see Medicare patients in the same way that you've always have. See them for the patient visit, you'll file the claim to Palmetto the way that you always do, and Palmetto issues the ERA. For the payment perspective, Clover will pay on a monthly basis to that primary care partner. So you will have a stabilized income flow. They'll look at the last 2 years of Medicare billing to establish a monthly amount that they will pay to their primary care partners. And then that will be reconciled quarterly. for if you've seen more patients and more money is owed to you, or if you've seen less and any money is owed back from that quarterly, monthly amount that they're paying. Mike, do you want to add anything into that? Okay, we'll move on. So for the other upfront incentives, so for your attributed lives, you will receive $4 per attributed member per month. So if you have, for instance, 300 members who are attributed to you as a primary care physician, that's $1,200 a month. And then there, for each E&M visit, there's a $30 bonus for filling out the Clover Assistant tool with each E&M visit. And we'll talk a little bit about that down the line, as well as the opportunity for upside shared savings. So there's robust upfront incentives for attributed lives, as well as the opportunity for shared savings with zero risk to the practices. So any questions before we move into the Clover Assistant? So Clover Assistant is the tool that Clover has utilized with their Medicare Advantage population for many years. It is an online portal that you enter quality information in, very similar to a SOAP note that you would fill out for a traditional MA plan. The reason that they're utilizing it, obviously one of the goals of DCE is to improve quality, and you are going to report on that quality through the DCE rather than individually going forward. And so they capture the quality data at the point of care to ensure the ease of MIPS reporting, which leads to overall higher quality scores as you're capturing it there for the patient visit. It reduces end-of-year chart chases to close quality gaps. And most critically, there's no requirement that a physician complete the Clover Assistant. The protocol that we see most often is for medical assistants or quality contacts to utilize that tool within a physician practice. And so won't spend a lot of time on this, but just some demo slides from the Clover Assistant, what the portal looks like. In terms of the time component that goes into this, the initial visit is generally the most time intensive, about 20 to 25 minutes to enter your patient information and establish really the baseline that you're going to be operating from. Subsequent visits, it's really just an update to that initial visit that really should take 10 to 15 minutes at the most, but minimal time component for the visit. And again, this is what triggers that $30 add-on to your traditional Medicare payment. And so obviously, focused on the diagnosis codes. We all know what the high drivers of cost within the plan is. If it's, diabetes, medication adherence, ER frequent flyer. So the Clover Assistant really looks at helping manage those conditions for your attributed patients. And so, checking in, as we all know, there can be diagnosis codes that come in if a patient has gone to an urgent care or to see another provider. This also helps manage that workflow when your patient may be going to see another provider to work on their coding and risk adjustment. For CMS, we all know what the HEDIS measures are and what we report on for MIPS. Again, that's what we're capturing within the Clover Assistant. Obviously helps try to manage medication. We know that that's a high driver of cost and provides options within the tool to help manage that for the patients, as well as medication adherence, statin use in persons with diabetes, to make sure that that is all staying on track for the attributed patients. And so here's just a demo of when you create your patients within the tool from that first visit, sort of checking off those boxes. If there's been a recent hospitalization, it'll provide that information to you. If there are diagnoses that are coming in off of other claims that you have not yet seen the patient for, it provides that information. So again, particularly if your patients are, accessing services, it provides that information in the tool to better manage your population and understand where your patients are getting cared. And so, as we said, very similar to a SOAP note, and this tool has been very successful in their Medicare Advantage market in managing the population and improving outcomes for the patients. So before we move on, are there a couple questions?
Yeah, Kelly, there was one question. It's more related to the dollars. It says, does having RHC status change anything about the financial impact of the incremental E&M additional dollars?
No, it should still be an add-on to each visit, even if you're paid on an all-inclusive rate.
Yep. Agreed. That's the only question I had so far, Kelly.
Okay. And so, in terms of why we're partnering with Clover and why we believe in the model, again, there's zero financial risk in initial funding. We've all seen ACO partnerships where upfront capital or the expenses of building the model are embedded into your overall performance and any potential shared savings that you get. In the Clover DCE, there's none of that. Clover is bearing all of the expense for building the model, which allows their provider partners to utilize that additional funding in that move towards value-based care. And in terms of, again, Clover is taking all the risk for actually managing that population. The physician partners have the opportunity for shared savings, but no financial risk if costs escalate above. All of that is Clover's responsibility. There are upfront financial incentives, a per member per month to fund care transformation, as well as the bonus on all of the E&Ms. So all of that is just additional funding for a population that you guys already have. It really adds that MA incentive quality to your red, white, and blue Medicare lives. The other component that is critical in this is that you'll have access to the entire CMS claims file. Everything for the patients that are attributed to you, you'll have access, where they're getting care, what their relevant costs are, that really will help fuel that transition towards value-based care, understand where your patients are accessing services, and how you can, again, continue to redirect them back to your practice, back to your hospital, et cetera. And, as the market continues to head towards value-based care, this is a premier opportunity with no risk to get access to data, get financial incentives up front, and learn more about your patients. So, any questions?
I guess I did want to make one comment for groups that have like hospitals that here. I think there's our typical hospitals have maybe between 500 and 3,500 attributed lives, and when you kind of walk through the financial example of that between the PMPM amount and a couple of visits with the extra $30, it ends up kind of working out to be about $108. If you see the patients 4 times a year, then add $60 to that. And so for those that have a couple thousand lives, it ends up kind of being a couple $100,000 pickup. And so it's just kind of in our mind, it's the difference. The question from y'all's perspective really kind of comes down to, is that increment worth the few minutes per patient that it takes to get the data in, regardless of the fact that there's additional, it's better information and maybe quality benefits, all that kind of stuff. It's at the end of the day, strictly from a financial point of view, it's all about that increment that's kind of a guaranteed extra funding versus the few minutes that it's going to take to get the data in there. And from y'all's perspective, I suppose you kind of have to decide whether or not that's worth it to you. But that's, in my mind, financially, that's what it kind of comes down to. Kelly, any additional thoughts?
I don't. Are there any other questions? I see a couple other red marks in the chat box.
No, the one comment was, I like zero risk and access to the claims data. It seems to be the upsides. Kelly, any other thoughts?
Nope, I don't have anything else to add. Obviously, if there are any other questions, feel free to reach out to us, and we will be back in touch with the participants about next steps.
Yeah, Kelly's probably mentioned that there is a sign up, a little short agreement that goes with this if you're interested. And I see there's a couple of y'all that we'll be following up with on there.
So thank you all for your time today.
All right, thanks.